Boa tarde a todos. Eu gostaria inicialmente de cumprimentar o Henrique, toda a comissão organizadora pelo simpósio, que está de alta qualidade. E agora nós vamos fazer aqui, comandar o bloco 7, né, que é o de-escalonamento de CDIS, né, uma vigilância ativa. Nós teremos aqui 3 debatedores e também a apresentação de 2 grandes expoentes desse tema CDIS, né? Gostaria de apresentar inicialmente aqui os nossos debatedores, que entrarão a posteriori da apresentação dos nossos speakers. Doutora Marina de Brot, que é patologista titular e professora do programa de pós-graduação do AC Camargo Cancer Center, secretária-geral da Sociedade Brasileira de Mastologia e secretária da International Society of Breast Pathology, mestre e doutora em patologia pela Universidade Federal de Minas Gerais, com fellowship em patologia mamária pela Universidade de Toronto e Memorial Sloan Kettering Cancer Center. O próximo debatedor é o Dr. Felipe Andrade, mastologista titular do Centro de Oncologia do Hospital Israelita Albert Einstein, membro da Comissão Científica da SBN Triênio 2023-2025. Teremos também o radiologista Dr. Almir Galvão, que é médico radiologista do AC Camargo Cancer Center e DASA, orientador do curso de pós-graduação do AC Camargo Cancer Center e membro da Comissão Nacional de Mamografia do CBR. E por último, mas não menos relevante, obviamente, a doutora Bruna Bonaccorsi, que é radio-oncologista, médica radio-oncologista formada pelo Instituto Nacional do Câncer, né, o INCA, no Rio de Janeiro, diretora clínica do Instituto de Radioterapia São Francisco, responsável pela radioterapia do Cancer Center Oncoclínicas Nova Lima. Como apresentadores, nós teremos o Dr. Andreas Karakatsanis, que ministrará a palestra Reduzindo e Evitando a BLS para CDIS, como proceder. Ele que é Associate Professor em Breast Surgery, Uppsala University Breast Surgeon, Senior Consultant Clinical Lead Breast Center Unit, Department of Surgery, Uppsala University Hospital Associate Editor for Breast Cancer, European Journal of Surgical Oncology and EUBreast Research Group Member. Nosso segundo palestrante será o Dr. Alastair Thompson, que já é uma figurinha carimbada aqui nos nossos congressos, né? E que é Professor in Chief Section of Breast Surgery, Baylor College of Medicine, Co-Director Lester and Sue Smith Breast Center e Co-Associate Director for Clinical Research do Comprehensive Cancer Center. Vamos iniciar as palestras. Esperamos que sejam brilhantes, tenho certeza que será brilhante, retornaremos em breve para discussões. Obrigado.
Ladies and gentlemen, thank you so much for the opportunity to share some thoughts with you on active surveillance for low-risk DCIS and the potential impact of the COMET trial. I don't have any formal conflicts of interest, but I'm going to talk about both European and United States trials in the DCIS area of active surveillance. I wanted to cover 4 topics briefly to remind you about DCIS and how it behaves, to then go through the various active surveillance, sometimes called active monitoring trials, and then to spend time at the end of this presentation thinking about whether we're ready for implementation of active surveillance in everyday practice. So what is DCIS? Well, I think we're all aware that it is a non-obligate precursor for invasive breast cancer. And on the left-hand side of this screen, you will see the terminal ductolobular unit, the epithelium of which, in the middle screen, shows how it proliferates. And then often there is necrosis and calcification in the center of the duct, which of course we can pick up, as you can see on the right-hand side of this screen, as comedocalcification on a mammogram. Now, despite the fact that not every patient with DCIS will go on to develop invasive breast cancer, it's a heterogeneous disease, in other words, and you can see on the right-hand side of this screen that the normal breast, the DCIS, can either go on to remain as DCIS or develop invasive breast cancer. We still treat DCIS, as you can see, as if it was invasive cancer, with a lumpectomy, with or without radiotherapy, or a mastectomy, and we often use endocrine therapy as well. And the fundamental question for this talk today is really to address the point of whether it is time to change what we do for particularly low-risk DCIS. So it's an uncertain behaving problem. What are the behaviors that DCIS exhibits? Well, sometimes there is a low risk of DCIS and sometimes not such a low risk of DCIS progressing to invasive disease. And as many of you are aware, young age, a palpable mass, more extensive DCIS, the presence of comedonecrosis and high grade are said to increase the risk of DCIS progressing to invasive breast cancer. But it's not quite so simple as that. The DCIS pathology is a little bit deceptive. For example, for the comedonecrosis, if you ask 39 specialist breast pathologists in the United States how they define comedonecrosis, you can see the wide range of what they will say is comedonecrosis based on how much of the center of the duct is occupied by this necrotic tissue. Perhaps worse still, given the fact that we use grade to make many of our decisions, on the top right of the screen, you'll see that if you ask 9 specialist breast pathologists from the Netherlands, from the United Kingdom and the United States to grade 450 examples of DCIS as grade 1 or grade 2 or grade 3, there is very little agreement, grade 1 in blue, grade 2 in green, grade 3 in red. And even if they group grade 1 and 2, lower risk DCIS together, the blue on the lower right screen, you can see that there is not complete agreement as to what is lower risk versus grade 3 higher risk DCIS of progression to invasive disease. So to try and unpick what is going on and to try and understand the behaviors of DCIS, I have the privilege to chair a project called the Sloan Project in the United Kingdom. And this is bringing Europe into the United States, if you like, and into Brazil. As part of the breast screening program, we've been able to accrue 15,000 women with non-invasive breast neoplasia, including DCIS, over a 20-year period. And nested within that study, there have been 2, what we call the forget-me-not sub-studies. In other words, those patients who've had a core biopsy as part of their breast screening program detecting a lesion, but have, for whatever reason, not gone on to have surgery for that detected by screening, core biopsy proven DCIS. So here are 2 of the papers we've produced. The one at the top, 79 patients, the one at the bottom, 311 patients who've had a core biopsy and who have not had any surgical intervention at the start of their treatment. And you can see the pink arrow shows you those patients with what is called high-grade DCIS have gone on, as in the bottom right pink arrow, to develop invasive breast cancer. Many patients with high-grade DCIS have gone on to develop invasive breast cancer. On the other hand, those patients, again, you can see with the pink arrows in the center of the screen, in the initial 79 patients at the top and the 311 patients at the bottom, those patients with low-grade DCIS, grade 1 DCIS, have rarely gone on to develop invasive breast cancer, as shown by the little pink arrow at the bottom right of that screen. Now, it would be nice to predict which patients are going to go on to develop invasive breast cancer and even to die of breast cancer. And there are moves afoot with this 822 RNA expression gene profiling to try and discriminate those patients, top right with the pink arrow, who are going to do well, from those patients, again shown by the pink arrow, who are not going to do so well as a consequence of their DCIS harboring genetic changes which are of poor prognosis. But this is not yet in the clinic. And similarly, looking at some of the stromal changes, which we now believe may be every bit as important in terms of progression of DCIS to invasive disease, we can't yet give you a stromal marker panel that will tell you a patient is at high risk of progression or at low risk of anything happening from her DCIS. So yes, sometimes DCIS progresses to invasive cancer, sometimes it doesn't. But how do we decide if surgery is needed? Well, at the moment, it's really quite difficult. So you'll all be aware that this is not a new topic for us, that for the last decade and more, the press, Time magazine, the New York Times here, has been raising the issue of whether we need to operate on everyone with DCIS. And this follows on from what has been done, for example, in prostate cancer. 2 trials, the PROTECT trial in the United Kingdom, the trial of active surveillance using biopsy in the United States, have demonstrated that we don't need to always intervene when there is a risk of invasive prostate cancer. Similarly, many thyroid malignancies, renal cancers under 2 centimeters in size, and early cervical neoplasia may not need to have an operation. So if active surveillance works for low-risk cancers, why can't it work for DCIS as well? And that really is the foundation of the active surveillance or active monitoring movement, which was really started by Adele Francis, pictured here. Sadly, she died of pancreatic cancer. And you can see many of us in the US, United Kingdom, Europe, and Japan have been trying to get trials going, which would allow for potential meta-analysis, including patient-reported outcomes and quality of life issues. Now, there are 4 trials, which I'm going to walk you through a little bit here. The first trial is the Loris trial, started in the United Kingdom almost 10 years ago now, which randomized patients to surgery, conventional treatment versus active surveillance. And you can see there's a Loris looking at you from the screen. Unfortunately, that trial closed, only having accrued 188 patients because it was so slow, so difficult to get patients with the grade 1 DCIS that they were focusing on. Then there is the Lord trial, based in the Netherlands, which after vacuum-assisted biopsy had been performed to demonstrate DCIS, and they only included grade 1 DCIS again, and using annual mammography follow-up, they were trying to randomize patients between active monitoring or active surveillance versus surgery. Unfortunately, that trial again was finding it very difficult to recruit. They recruited 73 patients, and now very smartly, they've converted that to a patient preference study where well over 1,000 patients, 1,200 plus patients have now gone into this study, aiming for 2,500 women to show their preference for active monitoring, active surveillance. 3 or 2 for every 1 who go out for the surgery are opting that way. And then finally, on the right, you can see the Loretta study, which is a single-arm study, tamoxifen given to every patient, and those patients are being followed up without any surgery for their DCIS unless they develop invasive disease. But I was going to focus really for the rest of this talk on the COMET trial, the comparison of operative versus monitoring and endocrine therapy. And you can see that this trial was designed as a randomized trial between guideline concordant care, which is surgery plus or minus radiotherapy plus or minus endocrine therapy, versus active surveillance, the topic of this conversation. And that trial, as you can see, is a little different from the 3 others. We had a younger age cutoff, had to be 40 or older, and we were looking at the 2, 5, and 7-year time points, really to look at the safety of doing this, not just the longer time points of 5 and 10 years of the other trials. And I'm happy to say that that trial closed in January last year, 2023, with just shy of 1,000 patients in it. So this is the COMET trial. You can tell in the top right that we were accruing patients of 40 years or more. They could be grade 1 or grade 2 DCIS. That's different to some of the other trials. Most patients in the United States do have an estrogen receptor measurement, and they needed to be ER positive if that had been measured. In the rare occasions where HER2 is measured, they could not be HER2 positive to enter the trial. And on physical examination or on ultrasound before they had their biopsy or on mammography, we were not allowing patients who had a mass already present. The other subtlety to this study is that all patients were allowed to consider endocrine therapy as they chose with their physician managing them, whether they were in the guideline concordant care or the active surveillance arms. And then our endpoints, as you will note here, were at the 2, 5, and 7-year mark, both for the primary outcome, which is invasive cancer diagnosis, and for the other outcomes, including patient-reported outcomes. Just a note in passing that if there was a change in the 6th monthly mammography, and remember, COMET trial in the active monitoring or active surveillance arm required 6-monthly mammography, unlike the European trials, which were annual mammograms. If there was a change suggesting progression of the lesion, we would biopsy it. As you can see further down this screen, the biopsy was fine. They would continue in the COMET trial. If the biopsy showed invasive cancer, they would progress to having surgery and subsequent treatments. So we're now at the point where we have at least 2 years follow-up in the COMET trial. We are going to report the primary outcome. The question is going to be is, are we ready for implementation of active surveillance for DCIS? So at the San Antonio Breast Cancer Symposium in about 6 weeks' time, we're going to see the primary outcome presented by Shelley Wang, the leader of this trial, and also the patient-reported outcomes by, alongside myself, the other investigator in this trial, Anne Partridge. The primary outcome is really a comparison of invasive cancers, which are found in either the active monitoring or active surveillance arm versus the usual care arm. And the primary reported outcomes in the patient side of things are going to be a comparison between the 2 arms of active monitoring, active surveillance, and guideline concordant care. So what I expect these 2 talks will tell you, and I'm sorry I can't share with you the actual data, but we'll come back to that in a moment, is first of all, the primary outcome, is it safe to have active surveillance, at least as far as the first couple of years are concerned when you have DCIS of low risk? And secondly, is active surveillance acceptable to the patients within this trial? And Anne Partridge will address that point. It brings us on to those studies being very publicly aware, made very publicly available, and patients being aware of them, so that in 2025, and that's not far off, we're going to be asking ourselves, if the COMET trial shows active monitoring, active surveillance is a safe thing to do, how will we identify these women? How will we identify women for whom active surveillance is a good option? Now, remember that the criteria for low-risk DCIS are that for this trial, you had to be 40 years or older, not for younger women, that you had to have grade 1 or 2 DCIS. There could not be microinvasive cancer. There could not be invasive cancer. And then it had to be ER positive with no mass on physical examination. You'll need to consider how will you monitor such women every 6 months. Mammography every 6 months was what we did in the COMET trial. Clinical examination, also important. Will you use endocrine therapy? Or should we await the longer term 5, 7, 10-year data? And with that, I'd like to conclude by suggesting to you that active surveillance for DCIS is an ongoing issue that we have to address. Are we ready for implementation? Well, you can see the bottom line there is not today, but we're going to get some data in December at the San Antonio Breast Cancer Symposium, which may lead us to reconsider our options for 2025. With that, I would like to thank you for listening to this talk and very much enjoy the conversations we're having on this topic. Thank you.
Thank you very much for this honorary invitation to discuss the hot topic of axillary evaluation and de-escalation of surgery in the setting of ductal carcinoma in situ. My name is Andreas Karakatsanis, and I'm an associate professor of breast surgery from Uppsala University and the chief of breast surgery in the Akademiska University Hospital in Uppsala in Sweden. So, an outline of axillary surgery. What could one potentially do? Well, more or less, we would have to technically choose between nothing, sentinel lymph node dissection, and axillary lymph node dissection, as these are the typical options that we have in any axillary procedure accompanying surgery for breast cancer. However, the short version is that we should not be doing any axillary surgery for ductal carcinoma in situ. Let's go on some facts on DCIS. Data based on previous studies suggests that the risk for underlying invasion in patients with a preoperative diagnosis of DCIS on core biopsy is approximately 20 to 25%. On the other hand, large retrospective registry-based series from the UK and Sweden have suggested that the risk of sentinel lymph node metastasis in pure ductal carcinoma in situ was found to be as low as 0.7%, and that was mainly due to microscopic foci of invasive carcinoma of the primary that had been missed in primary pathology review. Now, older data suggests that this risk may rise up to 9% if there is no microinvasion on the core biopsy specimen. More recent advances with the use of vacuum-assisted biopsies have been shown to lower the upgrade rate to 11% when looking into retrospective data. However, in the cases of large DCIS, such as the ones included in the prospective Cinnamon study from France, the upgrade rate was as high as 40% approximately. However, in this study, the average size of the DCIS was approximately 5.5 centimeters, and the majority of those were grade 3. With regards to enhanced imaging, unfortunately, meta-analytical data and a recent randomized controlled trial from France suggests that the use of routine MRI will not improve the outcomes of either diagnosis of the upgrade to invasive cancer or re-excision in the case of breast-conserving surgery. And small series looking into the use of a dedicated breast PET scan are promising, but still do not seem to address the problem, apart from the fact that health economy and cost effectiveness have to be accounted in. Finally, the traditional way of selecting patients at the risk of invasion has been nomograms. In the literature, one will find approximately 50 different retrospective studies with nomograms, where different cutoffs of size ranging from 4 to 5 centimeters usually, grade 2 and 3, the presence of comedonecrosis, clinical or radiological mass effect, or suspicion of microinvasion on core biopsy are risk factors. But once you remove all the low-risk cases, none of these nomograms retains prognostic significance. That means that we probably are in agreement of what a low-risk DCIS for underlying invasion looks like, but actually not the other way around. What about the guidelines? The guidelines suggest that one should pursue upfront sentinel lymph node dissection in the cases of either high risk or when it is considered very unlikely and improbable to be safely able to detect the sentinel lymph node. Therefore, you will see that in the red letters, the recurring theme is that of the mastectomy, followed by suspected microinvasion, high risk of invasion, and also high-risk features as we have traditionally considered them. Now, if we look at some facts on sentinel lymph node dissection in DCIS, so if one, while doing surgery for DCIS, would offer upfront sentinel lymph node biopsy, we would see that axillary evaluation in DCIS will affect treatment but not survival. And at the same time, regardless of type of primary surgery, it will increase the risk of complications and long-term morbidity. And that brings us to a conundrum. Some more facts that we need to address is usually that of that sentinel node can be omitted in any patient with DCIS that is planned for breast-conserving surgery. However, this is a belief stemming from retrospective evidence before the wide implementation of oncoplastic techniques, where extensive dissections and removal of large portions of the breast result in dramatic rearrangement and obviously consequences in the intactness of the lymphatic outflow. Previous studies have suggested that a previous excision, a large excision, or a periareolar incision are risk factors for failed sentinel lymph node biopsy. And looking more carefully to the prospective multicenter GATA study from France back in 2015, the researchers there showed that they had a 85.5 detection rate in this setting with negative scintigraphy, single tracer-based sentinel node detection, and reoperation within 36 days being factors contributing independently to failure of sentinel lymph node mapping. That brought the question for other techniques, and the sentinel concept, coined as delayed sentinel lymph node biopsy nowadays, capitalizes on the use of superparamagnetic iron oxide to remain in the breast and in the node for a prolonged period of time. Therefore, what we do is that we inject the breast with SPIO on the day of breast surgery, making sure that it migrates to the axilla. Once the migration in the axilla has been verified by a count on the magnetic probe, we perform breast surgery, but do not remove the sentinel lymph node. If pathology suggests that there is invasion that mandates to revisit the axilla, then we can perform a delayed sentinel lymph node biopsy. This study, the first sentinel study, started as a visibility study and multi-center international cohort study, recruiting 254 patients that, according to their national criteria, would have to undergo primary sentinel lymph node biopsy along with breast surgery. It was shown that this policy resulted in that approximately 4 out of 5 women could avoid upfront sentinel lymph node, and when delayed sentinel lymph node was performed in a median of 28 days after the first procedure, it was shown that the magnetic nanoparticle technique outperformed the isotope with or without the addition of blue dye, whereas we had higher nodal detection rate, and interestingly, only 28% of all the sentinel lymph nodes treated were concordant for the isotope and SPIO. Now, mind you, in the setting of upfront surgery, SPIO and isotope have been shown to be highly concordant, suggesting that this low concordance of the isotope that was injected in operated breasts and probably impaired lymphatics suggests that the accuracy of the procedure that we until now believed was feasible is quite questionable. And this is actually what I think that it is most interesting. In this table, you can see that the concordance was satisfactory only in the case that one had performed a single wide local excision without mobilizing the breast tissue at all. Whereas in cases where oncoplastic breast conservation or a mastectomy had been performed, the concordance outcomes were extremely poor. So both in the case of mastectomy, but also in oncoplastic breast conservation, injection of the isotope and attempt to perform sentinel lymph node biopsy after doing breast surgery resulted in an unacceptably high discordance. How did that study translate into cost efficiency? Interestingly, there was an 28% reduction of costs in the patients that had pure DCIS. With other words, the patients that would undergo an unnecessary sentinel lymph node biopsy. And the magnitude of this effect was so large that for the entire cohort, we had a reduction of approximately 9.8%. That meant that we were saving 10%, we were containing the costs by 10% just by including the patient in the study. Now, again, let's remember the guidelines. The interesting thing with the sentinel technique is that it can be implemented in any case where you potentially would consider performing an upfront sentinel lymph node biopsy in the setting of DCIS or any pre-invasive malignancy for that matter. So with the interim analysis of the sentinel, we did a post-hoc diagnostic study on how the guidelines performed. Now, this is a busy slide, but I would like to turn your attention in the middle column, the one with the area under the curve, that was more or less 50%, suggesting that the accuracy of the guidelines that are available and guide practice was similar to the toss of a coin. We tried to challenge that even further, going as far as seeing how experts would deal with that. So we convened a panel of 25 international experts, both surgeons and oncologists from 14 countries, and we exposed them for the same data set, asking them to tell us if they would consider upfront sentinel lymph node biopsy or not, and why. We specifically asked for individualized analysis in order to be able to detect if there were unconscious practice patterns, and our outcomes were upfront sentinel lymph node rates, the diagnostic accuracy of expert opinion, and the practice patterns. Again, it was interestingly shown that the area under the curve was low, and regardless of individual performance or use of the panel by majority or by consensus, these results were not improved. Interestingly, approximately 50 to 60% of patients with pure DCIS would be overtreated, whereas approximately 1/3 of patients that had underlying invasion would not be detected and would have to go to surgery one more time. We tried to identify if there were input variables related to medical specialty or the presence of clinical practice guidelines in the country of practice of each member, but there was nothing that suggested any type of correlation. Interestingly, the majority of the panel demonstrated predefined thought patterns, being more prone to offer upfront sentinel lymph node when mastectomy was intended, oncoplastic breast conservation, or with larger DCIS size without being able to identify a numeric cutoff. What would the next steps be in this setting? Optimally, we would be discussing to refine our available techniques and plugins of artificial intelligence in IV contrast-based methods such as the MRI or contrast-enhanced spectral mammography or AI-enhanced digital pathology might be promising. However, the data is still not there. The other solution would be more Sentinel, because the first study was a feasibility study that wanted to establish the validity of the concept. However, that trial was not powered in order to be able to demonstrate statistically significant differences in detection rates and concordances. Therefore, we went further with the ongoing Sentinel 2.0 trial, which is an RCT within a cohort. Schematically, the idea is similar to the previous Sentinel study, but the difference is that we randomize patients that need to go to delayed sentinel lymph node biopsy to doing the biopsy either with the SPEO first or the radioisotope first. If one of the tracer fails, then the auxiliary, that is the secondary method, becomes the primary method, and we are registering the results. Currently, the data accrued for this trial are coming from 4 countries and 9 hospitals. And we feel that these results will be highly relevant to clinical practice. In conclusion, upfront axillary surgery in the setting of DCIS should not be offered since there are valid alternatives. The diagnostic selection tools that we would need are yet to be established, and that means that we need to find a different way out in order to avoid overtreatment of the axilla. Current extrapolatory strategies from de-escalation studies, such as the omission of sentinel node, lacks support given the fact that none of these patients that would be appropriate for this type of discussion were included in these trials, which means that we need to accumulate more data, and I firmly believe that the Sentinel-2 trial is the way forth. With that, I would like to close my talk and thank you once again for the invitation.
Bem, agora nós vamos passar para a sessão de debates, né? A gente teve 2 excelentes palestras e eu gostaria de chamar inicialmente aqui o Dr. Felipe Andrade para os seus comentários iniciais e, se quiser, conduzir também alguma pergunta aos nossos palestrantes.
Boa tarde a todos. Inicialmente, agradecer o Henrique e toda a diretoria da Sociedade Brasileira pelo convite. É uma honra estar aqui com todos os presentes, a Marina, Almir e os professores, e você, Cristóvão. eu penso que toda a genialidade do Henrique, né, em trazer esses convidados, né, e trazer essa discussão, acho que certamente... Ok. Certamente é o prenúncio acho que de muita coisa que virá no futuro. A gente já observou uma série de descalonamento na cirurgia, e é o que a gente pode observar nessas duas aulas incríveis. Particularmente na aula do Dr. Andreas, é algo que eu já pratico há algum tempo. Realmente não me recordo do último caso de cirurgia conservadora em câncer in situ que eu fiz, linfonodo sentinela. Eu sempre dou uma oportunidade, e a ideia do SPIAL realmente é incrível, porque você pode protelar isso, e com ganhos ali de quase 80%, é realmente incrível. Bom, e do professor Alastair, que eu tenho a liberdade de chamar um amigo que eu fiz, que eu trouxe, pude trazer para toda a comunidade brasileira, apresentá-lo com grande honra e ver ele já, como você mesmo falou, né, Cristóvão, uma figurinha carimbada, nem sei se tem esse termo em inglês, mas é alguém frequente em todos os eventos, uma pessoa extremamente educada e um grande amigo. Trazer esse tema incrível, a gente fica esperando spoiler, né? E não vem, mas graças a Deus agora em San Antônio a gente vai ter, e tudo leva a crer que serão boas notícias, principalmente para os pacientes, né? Eu acho que antes de pensar em watch and wait para o carcinoma invasor, certamente a gente vai passar pelo carcinoma in situ, e esses trials, se tudo der certo, eles vão trazer essa oportunidade. Então, basicamente, eu vou deixar uma pergunta para o professor Alastair em relação às lesões precursoras, né? A gente vê ainda esse é um tema recorrente em relação à hiperplasia ductal atípica, ao carcinoma lobular in situ e tal, sempre como lesões que indicam uma cirurgia após o resultado de biópsia, considerando o risco de subestimação, né? Então, acho que a gente está olhando para um cenário de carcinoma in situ, onde o watch and wait deve acontecer, provável que aconteça um cenário mais favorável, e a gente ainda vê muita cirurgia sendo feita para essas lesões precursoras. Eu gostaria de ouvi-lo em relação a esse cenário, professor Alastair. Muito obrigado.
Obrigado. It's a real pleasure and privilege to be part of this discussion. For ADH, ALH, lobular carcinoma in situ, nowadays I do not excise these, providing we have got good biopsy material from our imaging team, usually larger bore vacuum-assisted biopsy, and providing that the imaging and the pathology are concordant. As you heard, I have the privilege to chair the Sloan project. One of those sub-projects from Sloan was to look at 2,500 women who had had that biopsy done with wide bore vacuum assisted, and to follow them up. At 1 year, there were 2 patients who had developed invasive cancer. That is all. And they were getting annual mammography. And at 3 and 5 years later, also very few patients, same number on the side that had the biopsy versus the contralateral side, had developed invasive breast cancer. So my personal practice, and I know not everybody does this, but my personal practice based on that British data is not to excise ADH, ALH, LCIS if we have good biopsy material, good pathology, and concordance between imaging and the pathology result, and the patient is happy to monitor, watch, and wait. Obrigado.
Gostaria de chamar agora a doutora Bruna Bonaccorsi, né, para as considerações iniciais dela também, Bruna. Vamos tentar ser conciso aí nas considerações, para que a gente possa aproveitar o mais possível aqui o nosso tempo com nossos palestrantes.
Obrigada, doutor Cristóvão. Parabéns para os palestrantes, obrigado pelo convite, né, do Henrique. Eu acho que o doutor Gustavo, meu colega da radioterapia, facilitou muito minha vida no módulo anterior, porque ele explicou bem a questão do descalonamento da radioterapia, né? O que a gente tem de evidências de poupar a radioterapia na verdade, é pelo NCCN, considerado depois de cirurgia conservadora, naqueles casos de baixo risco, que foi citado, menor de 2,5 cm, uma margem ampla de mais de 3 milímetros, grau 1, grau 2. E mesmo assim, mesmo esse guideline do NCCN preconizando que a gente pode fazer essa omissão da radioterapia, a gente tem um estudo da RTOG que mostrou, como o Gustavo bem falou, que decaiu pela metade a chance de recidiva invasiva e não invasiva, né? Partindo para a vigilância ativa, então, em relação à radioterapia, se dito isso, que após cirurgia conservadora a gente ainda tem um benefício da radioterapia no controle local, imagina se a gente escalonar tudo ao mesmo tempo, descalonar a cirurgia, descalonar a hormonioterapia, descalonar também a rádio. Então, a minha preocupação, na verdade, é a gente descalonar isso não tudo de uma vez, mas aos poucos, né, em partes, e eu ainda não tenho nenhum estudo com radioterapia. Eu acho que o COMET talvez precisasse de um outro braço com radioterapia para a gente ter essa resposta, né? Mas, por enquanto, a omissão por completo da radioterapia, igual a gente está vendo na cirurgia, apesar de ser um tumor um pouco com melhor prognóstico, talvez em algumas pacientes mais idosas, com uma contraindicação talvez relativa à radioterapia, né? Aquelas doenças de colagenase, não sei, mas a gente ainda não tem essa resposta para omitir completamente a radioterapia e fazer também a vigilância depois de não cirurgia nesses casos.
Ok, eu concordo assim com a Bruna fala, eu tenho também certo receio, a política de desescalonamento muito acentuado que está ocorrendo, né? Mas que há necessidade de escalonar vários tratamentos, não há dúvida nenhuma, né? Eu acho que a gente tem que focar realmente, mas não todos ao mesmo tempo. Gostaria de chamar também agora para participar da discussão aqui a doutora Marina de Brot, que é patologista, né? Para que ela possa fazer suas considerações e, se quiser, obviamente, fazer algum questionamento aos nossos palestrantes.
Olá a todos, boa tarde. Obrigada, Henrique, pelo convite. É um prazer estar aqui com todos vocês e agradeço também pela oportunidade de assistir às apresentações maravilhosas que tivemos. Bom, então, primeiro pontuando algumas questões das apresentações, que é muito interessante, né? Há uns 2 anos, no SCAP, que é o Congresso Americano-Canadense de Patologia, a gente teve a apresentação do Stuart Schmidt, exatamente avaliando essa questão da comedonecrose, né, e a variabilidade interobservador, né, entre patologistas sobre o que é comedonecrose e o que é necrose contata, que é aquela necrose focal. Então, a maioria dos patologistas considera que quando o lúmen está preenchido, acima de 30% do lúmen preenchido pelo material necrótico, a gente já chamaria de comedonecrose. Mas realmente não é uma questão que a gente tem consenso, né? E é interessante essa discussão, né? Que a gente ainda não tem muita resposta. Outro ponto é a graduação, né? A determinação do grau nuclear, né? Que a gente tem critérios objetivos, mas não deixa de ter uma subjetividade nessa avaliação pelo patologista. Mas quando eu acho que alguns patologistas têm dificuldade, né? E tendem a considerar muita coisa como grau 2, que na verdade seria grau 1, ou grau 3, um grau 3 focal, também chamando de grau 2. Então, eu acho que é muito importante a gente conhecer muito bem os critérios e aplicá-los, tentar ser o mais objetivo possível dentro dessa subjetividade que é inerente ao método. E um ponto, né, que foi trazido e discutido também nas apresentações, que é da inteligência artificial, né? Hoje a gente tem alguns trabalhos já em andamento correlacionando inteligência artificial, né, algoritmos de machine learning no HE, ou seja, na morfologia, na lâmina, com coloração de rotina, e tentando correlacionar com o prognóstico, com a evolução, né, com o curso natural da doença. Então, além da gente ter algoritmos para avaliar o grau nuclear e a gente tentar, né, combinando o olhar do patologista com o algoritmo, a gente chegar numa acurácia maior na determinação do grau nuclear, que é prognóstica, mas, além disso, algoritmos de machine learning com base no HE para tentar identificar aquelas pacientes com maior risco de evolução e que precisariam do tratamento completo, enquanto aquelas que poderiam ser poupadas com segurança, né, dos tratamentos. Então, acho que isso é algo que pode ajudar, né? Mas eu também estou muito curiosa para saber o resultado do trial clínico lá em Santo Antônio. E aí, última coisa, a questão dos trabalhos, as lesões de alto risco, né, detectadas em biópsia por agulha, aquelas que vão para ressecção ou não. Então, para papiloma, lesões papilíferas, né, papiloma sem atipias, neoplasia lobular não invasiva, né, tanto neoplasia lobular atípica como carcinoma lobular em situ clássico, a gente já tem muitos, e atipia epitelial plana, né, a gente já tem muitos dados na literatura que, quando tem concordância completa, imagem e patologia, a gente tem uma taxa de upgrade muito baixa, né, que fica abaixo de 5%, fica em torno de 3% dos casos, né, a taxa de upgrade na peça cirúrgica. O único ponto, eu acho, que ainda está em discussão é a hiperplasia ductal atípica, né, que a nossa Camargo, pelo menos, a gente continua ressecando todos os casos de hiperplasia ductal atípica, a gente ainda não está tão corajoso, mas para as outras lesões, né, de alto risco, a gente só resseca quando tem discordância imagem e patologia, né? Quando tem lesão de massa, quando tem microcalcificação residual e outros fatores de risco, aí sim essas pacientes vão para a resecção. Do contrário, é somente segmento.
Ok, obrigado, Marina. E dentro dessas considerações da Marina, eu gostaria de fazer uma pergunta breve aqui para o doutor Alastair e também ouvir um pouco do doutor Andreas, que ele fala sobre isso, porque o COMET, salvo engano, ele não tem uma revisão é um estudo multicêntrico sem revisão de uma patologia central, E dentro de todas essas dificuldades que a Marina colocou em relação a exatamente definir isso, a presença de o que é um alto grau, embora alto grau até que vai, mas assim, definir o baixo risco para você poder encaixar, recrutar essas pacientes. Como é que vocês têm adotado essa postura lá? O nível teve um treinamento especial para esses patologistas que participam dos estudos, dos vários centros que coletam pacientes?
Obrigado. I think that you have highlighted a very important point. We are always indebted and reliant on our pathologists, and I would take my hat off to pathology if I was wearing one. To answer your question, to enter the COMET trial, there had to be agreement of two locally based pathologists that the patient was suitable and had grade 1 or grade 2 DCIS. She was allowed to have comedonecrosis, recognizing that all the other trials, the European trials, you could not have comedonecrosis, you could not have grade 2 in. So we have been much more open, much more encompassing to allow more patients into the United States trial, in the belief that if this trial is going to change practice, we have to recognize that it is the local pathologists who will make the decision and guide the surgeons. Obrigado.
With regards to that, I completely agree on that. If I would have to choose, I think that the committee is much closer to what could be implemented in everyday practice once the data is out there. So, whilst understanding the need for central pathology review, we need to acknowledge that this is something that will more or less never going to happen in routine practice. So we need to have criteria that allow for that. About the comment of why not radiotherapy instead of systemic therapy. I think that this would be a less, so to say, attractive option, in the sense that until we get more data on how to treat in breast cancer recurrence following breast conservation and previous radiotherapy, had one performed radiotherapy in a breast like that would potentially get a DCIS down the line at some point, the surgical options would be limited to those of the mastectomy in the paucity of data, And that would make such a trial as a surgical option and as a patient-friendly option less attractive, I think. That's my gut feeling about it.
Ok, temos ainda mais 5 minutinhos. Temos ainda mais 5 minutinhos aí de debate aqui. Gostaria das considerações do doutor Almir Galvão.
Muito obrigado, Cristóvão. Muito obrigado, Henrique, pelo convite. Parabenizar aí a comissão organizadora. O evento realmente de excelente nível. Estou acompanhando aqui desde de manhã e todas as discussões excelentes. Parabenizar aí também o doutor Alastair e o doutor Andreas pelas apresentações brilhantes. E eu queria aproveitar para fazer umas perguntas aí do ponto de vista prático, assim, da experiência do doutor. São duas perguntas. A primeira para o doutor Alastair sobre a experiência dele durante o estudo, né, e como seria esse acompanhamento das pacientes durante esse active surveillance. Ele falou de fazer exame clínico, mamografia a cada 6 meses. Eu queria saber, assim, qual o critério que eles usam, por exemplo, para fazer uma nova biópsia, o aumento do número de calcificações, e, assim, na experiência deles, quantos % dos pacientes necessitam de novas biópsias durante esse acompanhamento? E depois, a segunda pergunta, aí para os dois, para o Dr. Alastair e para o Andreas, se eles veem algum papel para métodos de imagem funcional vascular, com a ressonância magnética ou a mamografia com contraste, para selecionar os pacientes que poderiam ou ir para o acompanhamento, né, para uma active surveillance, ou para também poupar a necessidade de uma biópsia de linfonodo sentinela, por exemplo, se esses métodos vasculares poderiam ser usados para a gente selecionar aqueles casos, aqueles tumores, digamos assim, de menor grau, menos agressivo, com menor risco de ter um componente invasivo associado, por exemplo.
Thank you so much for your 3 questions. First of all, the criteria we used was any change on the 6-month mammograms. Usually we were looking for an increase of 5 millimeters in the microcalcification or the stromal deformity, and we would then do the biopsy as a consequence. And to your other point about the vascular imaging, this is an area that I don't think we know enough about. MRI is perhaps not so good for DCIS, but contrast-enhanced mammography is emerging as a very powerful, cheap, user-friendly for the patient and the community tool. So I love your questions. You're pointing where we need to go in the future. Thank you so much.
Yeah, I would agree 101% with Alastair on that. With regards to MRI in specifics, looking at the principle and the technology, we know that a low or intermediate grade DCIS will not have promoted neoangiogenesis, meaning that the non-mass enhancement would not be normally expected to be accurate. Therefore, if we are looking for the low-risk DCIS, we would not expect that this low-risk DCIS would behave as a grade 3 DCIS on MRI imaging. Moreover, in one of my slides, I think I mentioned the fact that MRI is being performed often in the setting of DCIS. The criteria are more or less arbitrary, and there is no clear-cut data supporting that. Interestingly, the randomized control trial from Malaysia, the IRCID trial, did a subgroup analysis in order to see whether there would be subgroups in which MRI should be tested in future DCIS trials, but they did not find anything promising, so as to say. On the contrary, I think that contrast-enhanced spectral mammography, tomosynthesis, the integration of the two in AI protocols, which is something that we see emerging on trials. I think that these are tools that will enable us to select properly in the future, and they will be, as Alastair said, patient-friendly and community-friendly.
Muito bem, eu gostaria de agradecer imensamente aqui mais uma vez a comissão organizadora pelo convite, agradecer os nossos speakers, Dr. Alastair Thompson e Dr. Andreas. Foi uma pena que o tempo é curto para debater, tenho certeza que todos nós aqui gostaríamos de continuar, mas o tempo urge e vamos passar para a próxima sequência de palestra, o Bloco 8. Obrigado a todos e uma boa tarde.